Peter D., Product Manager at One Lambda. I'm very excited to introduce our featured guest speaker, Dr. Nicole Valenzuela. Dr. Valenzuela is the Assistant Director at the UCLA Immunogenetics Center and Assistant Clinical Professor in the Department of Pathology and Laboratory Medicine. She's authored multiple publications, including most recently, HLA Class II Triggered Signaling Cascades Cause Endothelial Cell Proliferation and Migration, Relevance to Antibody-Mediated Transplant Rejection, in the Journal of Immunology. Her current research is focused on characterization of the differences between microvascular and large vessel endothelial cells from multiple tissues of origin in their intrinsic and inducible inflammatory states, and investigating the chronic inflammatory phenotypes of endothelial cells. Today, she'll be providing an overview of single antigen BEAD testing, along with a discussion on the interpretation of HLA antibody profiles using serum dilution and C1q screen in parallel, and consider its utility to guide and monitor efficacy of desensitization therapy. In her talk, Assessing HLA Antibodies, Can We Understand the Strength? This presentation will be recorded for future viewing through the One Lambda website. During the presentation, please feel free to type questions in the open field on the bottom right of your screen directed at the panelists. Questions will be answered at the end of this presentation. Also note, a short survey will be emailed to webinar participants in 7 to 10 business days. 1.0 contact hours of ABHI approved CE credits will be provided to participants who complete the survey. It's now my pleasure to turn today's program over to our presenter, Dr. Nicole Valenzuela.
Thanks, Peter, for that introduction, and thanks to everyone for joining us this morning or this afternoon, depending on where you are. As Peter said, this morning's lecture will seek to answer whether we can understand the strength of HLA antibodies using our current methodology. And I'd like to point out that all of the views that will be expressed are mine and mine alone. So I'll attempt to be as much as possible vendor agnostic and give a brief overview of solid phase single antigen testing for HLA antibodies, including the current limitations and how they lead to caveats in our interpretation of these tests. I'm going to build upon the guidelines from two recent consensus documents, one that was published in Transplantation in 2013, and the other most recently from the STAR workshop that was published in AJT in 2018. So I'll try to provide some of the scientific and technical rationales behind these recommendations from these documents, as well as present published studies and real-life cases from our own center that illustrate why these recommendations were made. And I'll point out the literature on the potential applicability of serum dilution and in vitro complement assays in parallel. So HLA antibody detection has evolved from the least sensitive but quite specific for rejection test, microcytotoxicity, all the way to the very sensitive and detailed assays that we have today, which are single antigen testing. So the CDC was quite specific for rejection, particularly hyperacute and accelerated rejection, but it's the least sensitive test, and it was not specific for a single HLA antigen. In contrast, we now have very sensitive ability to detect HLA antibodies that are specific for single HLA antigens. However, many studies have shown that there's less direct and clear prognostic value for outcomes depending on the study. So this audience will already be familiar with this technique, so I'll only briefly cover it. Current single antigen assays employ multiplexed dye-impregnated beads that are coated with single HLA antigens with a current maximum of about 100 unique specificities on the most widely used Luminex machine. When patient serum is mixed with these beads, alloantibodies bind and then are detected with a PE-conjugated anti-IgG antibody. The readout is a fluorescence intensity that is numeric, and it is variable. So this has led some investigators to see if we can rely on MFI as an indicator of how much antibody is there. And indeed, many centers, including our own, do rely on the MFI readout to interpret how much antibody is present. But as we'll discuss today, the MFI is not always a reliable tool on its own to assess the quantity of HLA antibodies. So study after study in this modern era of solid phase testing has shown that patients who make DSA fare significantly worse overall than patients who don't. But what's notable is that it's really the patients who experience rejection that lose their grafts at the highest rate. And this is true across solid organs in liver, heart, and lung transplantation. So DSA alone are actually inadequate prognostic tools to predict concurrent AMR, and although it's important, the presence of DSA is not a binary determinant of long-term graft loss. So an important question is how we can better identify the characteristics of HLA antibodies that more accurately predict outcome. So one approach has been the introduction of assays that actually seek to identify whether antibodies can activate complement, and there are two currently available, one of which measures binding of exogenous C1q protein to the single antigen beads, and another that measures a downstream complement split product C3d that's produced upon catalytic activation of serum complement. Many studies have demonstrated a correlation between C1q positive or C3d positive DSA and outcomes. This is one well-cited example that was able to delineate the patients who have DSA and poor outcome from those patients who had DSA but didn't experience as poor of an outcome. And here's another of many examples of a significant association of C3d positive DSA with worse outcome. So these could potentially stratify DSA positive patients into two risk groups. But what's really important to remember is that nearly every study has commented that the DSA MFI, when you detect total IgG, was generally significantly associated with positive reactivity in these complement tests. Again, suggesting that indeed the strength of the antibody might be the most important indicator. So here's an elegant illustration of the relationship between the antibody MFI and the complement activation, either C1q or C3d. And what you can see is that the red bars are antibodies that are binding to complement, and their MFI is generally higher. So if complement activation in vitro is closely tied to antibody strength, it might be valuable to see if we can better utilize our basic assay to estimate antibody quantity. Another important study showed that it's the strength of the antibody in the cross-match that's correlated with outcome. So there is some indication that antibody quantity is important. In this study, Orandi et al. Compared patients who were transplanted with preformed DSA that was either detectable by cytotoxic cross-match in the yellow line, detectable by flow cross-match but cytotoxic negative, or in the purple line, detectable only by solid phase assays. And you can see that the strength of the antibody in the cross-match really did correlate with the risk of graft loss. So this leads to the focus of this lecture of whether we can really understand the strength of antibodies to HLA using our current tools. One important limitation to point out is that the MFI readout is actually variable, and it's variable across vendors, across lots, across laboratories, and even intra-laboratory run-to-run. So this CTOT study sought to standardize the readouts in order to enable analysis of data from multi-center trials. And what they found was that the variability in the MFI readout could be as much as 50%, but especially after standardization of the bench work, the protocols, there was still variability as much as 25%. It's notable that the variability is higher at lower levels. And so this idea of the inter-assay variability in the MFI readout led to the STAR Workshop's recommendation that we should not consider differences of 25% or less in the MFI values clinically significant. And in particular, low MFI values less than 1,000, which have quite high variability, we might need to increase our stringency. So a doubling from 500 MFI to 1,000 MFI really shouldn't be considered clinically significant. So these solid phase assays are not quantitative, but they may be semi-quantitative. Indeed, published reports and my own experience using monoclonal antibodies does demonstrate that there is a clear relationship between the MFI and increasing concentrations of antibody. So this study from a French group described chimeric monoclonal antibodies directed to class 1 and class 2 antigens that were dosed into the assay at increasing known concentrations. And what these curves show is that the MFI does increase when you have increasing known amounts of antibody. So there must be some relationship between MFI and antibody amount. Serum, of course, is a mixture of antibodies of many different specificities against HLA as well as thousands of other antigens. And in addition, serum contains numerous proteins that may interact in this system. So the presence of polyclonal antibodies is an important second factor to consider in whether MFI is a valid readout of antibody quantity. So one challenge that limits the extrapolation of the kinetics of a monoclonal antibody is that HLA antigens share epitopes among the cross-reactive groups. And when we put these antibodies into solid phase assays, we see that there is spreading of the antibody across multiple beads. And the breadth of the reactivity is different depending on the frequency and affinity of each antibody clone for its respective epitope. So in this example, we may have antibodies to the A2, A28 CREG, and you can see that it may be the same clone recognizing a shared epitope, but those antibodies are in fact spread across multiple beads. And so when we detect these antibodies with a readout of a PE conjugated secondary, the PE readout is going to be different across the beads. So this is best illustrated actually going back to monoclonal antibodies, where you can compare the MFI readout of known concentrations of antibodies that recognize different epitopes. So at a very high concentration, antibodies present at 500 nanograms per mil, those that recognize restricted epitopes that are present on only a few beads have a high MFI, but a chimeric antibody that recognizes all 96 HLA class 1 beads at the exact same concentration has a much lower MFI. But the differences even among these CREG-specific antibodies here become apparent if you dilute the antibodies further. So the A2 CREG antibodies have a comparable MFI at 300 nanograms per mil. Each of those recognizes 6 beads in the multiplex panel. But this A1 CREG antibody actually recognizes 11 beads. And at the same concentration, the MFI is lower on each of those beads. And it becomes nearly negative at 200 nanograms per mil. So even in the same total amount of in the presence of the same total amount of antibody, depending upon how many beads or HLA antigens are recognized, that will affect the readout of the MFI quite substantially. So in practice, what this means is we may have antibodies that are restricted to a private epitope, in which case we have many antibodies bound to the bead and the MFI will be higher. But if the epitope is shared as a public epitope, then the same number of antibodies actually gets spread over multiple beads. And this is probably best encountered in clinical practice with antibodies that are reactive with the public epitopes BW4 and BW6. So here I'm just presenting 3 examples in which each patient had only one DSA to an A locus or B locus antigen, but the pattern of reactivity was clearly to a public epitope. In each case, the results of the flow crossmatch with that donor were stronger than what we would have predicted if the MFI had just been directed to a single antigen. This is because the antibody becomes concentrated on the donor cell. So you can see in this last example of a patient who has antibodies to BW6, the DSA is to B7, and it's only around 4,000, but the flow crossmatch was quite strong, over 200 median channel shift. And so this is something that we have to keep in mind when we're trying to predict reactivity with the donor antigen. Therefore, the STAR workshop guidelines suggest that laboratories should put in place a mechanism to detect this phenomenon of potential epitope sharing, because it may lead to under-recognition or underestimation of DSA. Another important consideration is that the assay has necessary lower and upper limits of detection. So returning to this curve for a minute, you can see that when you increase the amount of antibody tenfold, you actually have already reached your level of saturation around 12,000 to 20,000 MFI. So because of this necessary upper limit of detection, it becomes difficult to assess antibodies that are at saturation and evaluate the efficacy of desensitization in patients with very strong antibodies. So here, there's a tenfold increase in the amount of antibody that's present, but it cannot be detected because it's at the level of saturation. So one approach to assess these antibodies at saturation is to dilute the serum. So because of this, the STAR work group also cautions that MFI and titer are not the same thing. And I think this stems from the interchangeable use of MFI and titer in the literature, but the work group is really emphasizing that this is not, they are not analogous terms. So what is antibody titer? Well, titration is used in many other serological tests, such as those for autoantibodies or against infectious disease pathogens or to assess the efficacy of vaccination, and it's also used in blood banking. So titration should be strictly defined as the practice of serially diluting the plasma or serum until the reaction is negative. And this is usually done when a test is simply a positive or negative result, so the test is inherently non-quantitative, but by titering the antibody out, you can obtain a number that can be used as a quantitative readout. So the titer is the highest dilution of plasma or serum that still demonstrates, in this case, agglutination. So titration in agglutination assays is widely used to detect antibodies to antigens of interest, and it can also be used to measure changes such as an increase or a decrease in the antibodies that are present. In this case, the last dilution that produced agglutination of red blood cells was 1 to 160, therefore the titer of the antibodies is 160. If the last dilution that produced agglutination was 1 to 80, the titer would be 80, which would be a lower amount of antibody. So antibody titration has been most elegantly described by a Nott-Tambor's group, and it seems that it is informative in AMR diagnostic. So the data is really quite beautiful here, where the antibody titer, that is the dilution that produced the last positive result, is shown on the x-axis. And the IgG MFI of that antibody in the undiluted serum is here. So you can see that antibodies at saturation in undiluted serum are actually still detectable at very high dilutions of the serum. However, this is many, many single antigen tests just to do one antibody assessment in one patient. And so we find that this is extremely expensive and at this time cost prohibitive. But I think what's important is that we should evaluate this approach with more studies analyzing the DSA titer, this number here, and transplant outcomes. So the first case study I'll present is one in which we needed to assess HLA antibody responses to desensitization pre-transplant in a patient whose antibodies were at the level of saturation in the test. So this is an example of a very highly sensitized young man who was awaiting his second heart transplant, and he was undergoing pheresis-based desensitization. So we tested him at baseline and then weekly through the course of his desensitization. And then he experienced infection, so desensitization was halted, and we tested him again several weeks later to determine whether these antibodies had rebounded. If you just track the MFI of his antibodies in undiluted serum, it looked like actually nothing was happening, even though he was being pheresed regularly over these weeks. But if you test the serum at a 1 to 10 dilution, you can see that actually the antibodies are still quite strong at baseline, but are trending downward over time throughout the course of his desensitization. And what's really notable is that after this infectious event and the halting of his desensitization, in the undiluted serum, we couldn't detect really any significant change in the MFI of these antibodies, but the rebound is quite apparent in the serum that's diluted at 1 to 10. We also tested C1q in parallel with the 1 to 10 dilution of his serum, and you can see that it does track with the MFI in this case, but it was quite positive all throughout because in the undiluted serum, his antibodies were still very strong. So the second case study presents another example where we were able to predict which antibodies might reduce with AMR therapy using a dilution study at baseline. So this was a 33-year-old woman who was presenting for her first heart transplant. She had a significant allosensitization history to include cardiac repair surgeries with placement of homografts from deceased donors, blood transfusions, and at least 2 pregnancies. She was very highly sensitized with a CPRA of 100%, and as I'll show you, she had antibodies to everything on the panel except for self, and it was the alleles of self. We also do a cytotoxic antibody screen as well as a phenotype solid phase assay, and both of those were 100%. So she reacted with every donor on those panels. So in order to get her transplanted, the patient underwent desensitization that was pheresis-based along with IVIG and rituximab. And this just shows her single antigen at baseline. This is class 1, and here is class 2, and you can see that really the only things that are negative are the self antigens. So in this case, we perform complement assay and dilution in parallel, and this helps us understand which antigens actually might be amenable to pheresis in order to predict whether we can remove some unacceptable antigens for her in the future. I do want to note that we always pre-treat our sera with DTT prior to evaluation in single antigen, and I'll explain why this is important in the next set of slides. So here's an example of some of the patient's antibodies which are directed against a shared epitope in DP. They were all C1q positive. They were all over 15,000 in undiluted serum. The MFI did go down at 1 to 10 and became undetectable at 1 to 50. So the way that we interpret this pattern at baseline is that she does have very strong antibodies at saturation, but they are reducing upon dilution, and that she might actually respond to pheresis in that case. Indeed, after 3 weeks of her desensitization, you can see that these antibodies are no longer C1q positive. The MFI in undiluted serum has come down quite a lot, and they were no longer detectable in either of the dilutions. And we predicted that they would likely continue to reduce with further pheresis. And so at 6 weeks, they were completely undetectable. So the initial dilution study at baseline helped us to identify antibodies that would be amenable to pheresis. But she also had very strong antibodies to many C-locus antigens. So at baseline, antibodies to these two examples of the many antibodies she had, C2 and C4, both were over 10,000. And actually, antibodies to C2 remained quite strong even when diluted to 1 to 50. So our interpretation of these antibodies is that they are extremely strong and they may not respond well to pheresis. And indeed, what happened after 3 weeks is that the MFI stayed quite strong in undiluted serum and remained strong at 1 to 50. And at 6 weeks, we did start to see a decrease, but really only at the dilution, 1 to 50 and 1 to 10. So this actually looks like it's a shift in the titer of the antibody that you couldn't detect in undiluted serum. So this approach is also useful in the post-transplant period in patients who are experiencing rejection with strong DSA. So this was a young female recipient of a heart transplant 10 years prior, and she presented to clinic with allograft dysfunction. On biopsy, they found that she had AMR, and we found that she had 2 strong DSA. So what we did was we detected these DSA in undiluted serum, and they were both over 10,000. And then we diluted the serum to see if she might respond to pheresis. And indeed, they pheresed her, gave her Rituxan and IVIG, and these DSA did reduce over time. So this dilution study helped us to see that these antibodies that were nearing the level of saturation were probably going to reduce with AMR therapy. So to summarize these case studies, we find that when HLA antibodies are at saturation, a dilution study does aid in assessing how strong those antibodies really are and predicting whether they will reduce with therapy. Something that using C1q and single antigen in parallel has shown is that the MFI of the single antigen test doesn't always correlate with C1q positive or negative. And several groups have shown that while there is a general concordance between IgG, MFI, and C1q positivity, there are subsets of patients who have C1q positive antibodies with rather low MFIs. And what they've shown is that you treat the serum, and serum treatment is actually quite variable. In this case, they treated the serum with EDTA, that the MFI does increase, and then you get a better correlation between C1q or C3d positivity and IgG, MFI. So these types of observations helped identify the phenomenon of serum inhibition, which is colloquially but erroneously termed prozone. So this observation leads to the caution from the STAR work group that failure to routinely rule out serum inhibitors may also lead to underestimation of HLA antibodies and DSA. So there are now many studies that have illustrated this phenomenon. In this case, we have a comparison of untreated serum and serum treated with EDTA. And you can see that there are discrepancies in the MFI depending on whether the serum was treated or not. And these investigators were able to show that it was dependent on complement that was present in the serum, predominantly C3, because C5 depletion and factor B depletion had no effect. And now I count more than 6 different serum treatments or solid phase modifications that have been reported to try to overcome this effect. And those include DTT treatment, which is what our laboratory uses, depletion of complement as is shown here, hypotonic dialysis or melon column, or actually swapping out the secondary to utilize a biotin and streptavidin conjugate instead. So there's high variability across laboratories in which serum treatment is being used. And what I think is really needed is a study like this study that was published by the Cedars-Sinai lab, where they actually compared, using the same serum, multiple methods of serum treatment head-to-head in order to see whether there was concordance between them, and I guess really to identify which serum treatment was the best. But how do we define the best? It really gets back to which MFI is actually clinically relevant. So if we can pretreat the serum with DTT or EDTA and get a higher MFI, is that higher MFI actually relevant to the clinical outcome more so than the MFI in untreated serum? I just wanted to point out that interfering substances are also observed in other clinical laboratories here in transfusion medicine. So originally this similar odd reactivity was assigned to novel blood groups, but eventually they realized that individuals exhibit what were called high-titer, low-avidity antibodies. And this certainly isn't my area of expertise, but I considered it interesting and relevant to this discussion. So in blood banking, they utilized AHG for agglutination, and in some cases they observed weak reactivity in undiluted serum, but very high reactivity in higher titers against red blood cell antigens. And much work has been done in this field that ruled out the clinical significance of these antibodies, but it's noted that they may mask underlying alloantibodies that could cause hemolytic transfusion reactions. And so their approach to eliminate the interference of these antibodies is actually dilution. So this phenomenon does impact serological testing beyond HLA antibody detection. So for best practice, this consensus has concluded that labs must put into place some measure to remove serum inhibition, but which of these reported treatments is best is really not clear yet, and we're still awaiting studies to identify that. So this brings me back to case study 2, where we asked the question, is my patient actually exhibiting interference or prozone, and how do we interpret that in the context of her desensitization? So her single antigen test at baseline prior to initiation of desensitization therapy is shown here. And at NEAT and at 1 to 50, what you can see is that there are actually antibodies in this red box that move way up upon dilution, and they were predominantly to the A1 and A10 CREGs. So here is just a select few of those showing what it looks like. The MFI actually in undiluted serum was less than 10,000, but it was surprisingly C1q positive, and this doesn't track with our typical experience that antibodies over 12,000 activate C1q. When the serum was diluted at 1 to 10, actually these antibodies became negative, and it was only at 1 to 50 that the MFI became quite strong. So how should we interpret these antibodies now that we know that they have interference? Well, we know that they're falsely moderate, and they're actually quite strong. How they behave over the course of her desensitization is interesting. We could actually only see changes in the MFI of these antibodies at dilution. So after 3 weeks of desensitization, these antibodies were no longer negative at 1 to 10. They became detectable at 1 to 10 and remained quite strong in general at 1 to 50. And after 6 weeks, they were still detectable at 1 to 50. So this is again analogous to a shift in titer, but we didn't technically titrate the antibody. And I'll note that because of the cost, we consider it sufficient to say that an antibody that's still detectable at 1 to 50 is quite strong and likely unacceptable. So even if we don't obtain the actual titer, we can still say something about the risk of that antibody. And here is just illustrating 3 of her antibodies. If you looked at the MFI over time in undiluted serum, they actually went up, but at 1 to 50 is the only time that we could detect that they were coming down. So this helps us evaluate the efficacy of desensitization for these types of antibodies. So dilution helped predict which antibodies might respond to pheresis-based desensitization, but without dilution, we might have erroneously interpreted the response to therapy in these patients as either not efficacious or that she was experiencing some rebound because the MFI was creeping up. And these very highly sensitized patients actually may have falsely low MFI for some of their antibodies, even though we treat with DTT, and other groups have reported this phenomenon even in EDTA-treated serum. What I think is helpful is actually having C1q in parallel, because we are now quite suspicious of a pattern like this patient had, where antibodies have a moderate MFI or a weak MFI in the undiluted serum but are C1q positive. We now suspect that these antibodies may have interference, and that will trigger us to go on to do a dilution study if it's clinically indicated. So the last two case studies will really try to address the question of whether this phenomenon is actually clinically significant. So I think these case studies support the clinical relevance of these very high MFI antibodies, especially those who have interference. And in both cases, we had to ask ourselves, why is the CDC positive? We wouldn't have predicted that. So Mrs. X was a 53-year-old woman who received her first liver transplant, and we perform a baseline single antigen and perioperative flow and cytotoxic cross-match for liver transplant patients. She was highly sensitized. Her sensitization history included pregnancy and transfusion, and what we identified in the baseline single antigen were 3 DSA, A2 at around 8,000, B44 at around 4,000, and B62 at around 8,000. But the cross-match results were unexpectedly, we would have expected a positive cross-match, but the cross-match results were unexpectedly strong given these several moderate DSA. So the T flow was 380 median channel shift after pronase. The B flow was 444 median channel shift after pronase, and both the T and B cell cytotoxic cross-matches were strongly positive, 8 all the way across. So I posited this as a case study. What would you do in your laboratory if you obtained these results? So you could say there's DSA, the cross-match is positive, this is how we would have expected it, and do nothing. You could think that there's something wrong with the cross-match and repeat it. You could perform complement activity testing if you thought that that would inform you about the cytotoxic positive cross-match, or you could perform serum dilution suspecting that these antibodies might actually have interference. And I'll just point out that we've done a study of more than 600 cross-matches in our laboratory, all of which were DSA positive. And from this study, we have a good sense of how much DSA is required to cause a positive cytotoxic cross-match. So we very, very rarely encounter a positive cytotoxic cross-match when, even with multiple DSA, the MFI is cumulatively less than 20,000. So in this patient, it was barely reaching that, and we were quite surprised by the cytotoxic positive cross-match. So we felt that our result was inconsistent, and here we used serum dilution to determine whether the patient's antibodies were exhibiting interference. So we diluted the patient's serum at 1 to 10 and 1 to 100, and at 1 to 10, the DSA to B44 diluted out, and it was no longer detectable at 1 to 100. B62 reduced at 1 to 10 dilution and was no longer detectable at 1 to 100, but the DSA to A2 actually became 17,000 MFI at a 1 to 100 dilution. And so our interpretation is that actually this DSA to A2 was exhibiting interference, and this was contributing to the very strong positive flow cross-match and the positive cytotoxic cross-match. The second case study that illustrates this point is Mr. Y. So Mr. Y was a 48-year-old man who had a previous kidney transplant from a living donor 16 years prior, and he was presenting for second transplant with a potential donor who was his brother. He was sensitized, but not very highly sensitized. At evaluation, his CPRA was only 86%. And what we noticed was that the typing of the previous transplant and of the potential donor actually were identical. So they were HLA identical. And we found out that the first transplant, which was performed at another center, was from another brother of this patient. Therefore, the potential donor was HLA matched to the patient's failed allograft. So what we identified in single antigen testing of undiluted serum was that there were definitely 4 and possibly 5 DSA, A29 at 8,000, a weak DSA to B51, DQ2 at 10,000, DP11 at 2,000, but the DQ7 pattern was very weird and suspicious to us, and I'll show you that in a moment. So the cross-match results, again, were unexpectedly stronger than what we would have predicted based on what we knew about his DSA. The T-flow was concordant with the strength of the class 1 DSA, and the cytotoxic cross-match on T cells was negative, but the B-flow was very strongly positive, 516 median channel shift after pronase, and the B-cell cytotoxic cross-match was also positive. So here is showing the patient's pattern of reactivity to DQs, and I'll illustrate why this pattern was suspicious and difficult to interpret in undiluted serum. So the patient himself was DQ5 homozygous, and these beads were quite clearly negative. All of the beads carrying the DQB102 antigen were positive over 1,000, but the spread of the MFIs was really different. Here, this is just barely positive, whereas the strongest bead is over 17,000. The similar pattern was observed with DQ8, where we had one borderline bead and 2 strong positive beads, and DQ9 as well. And for DQ7, we had 3 negative beads, less than 1,000, and 2 strong positives. So in this case, sometimes we look for DQ alpha patterns, but what you can see is that there's not really a clear DQ alpha 103 pattern, because here we have a positive, here we have a strong positive, but these two have quite different MFIs, and the DQ alpha 10302 beads in particular are exhibiting the lowest reactivity. And what's notable is that those beads that were borderline or negative actually represented the exact combinations that were present in the previous donor. So the previous donor was DQ alpha 105 with DQ7. So what we did was we diluted the patient's serum further at 1 to 10 and 1 to 100. And here it became clear that those beads that were borderline and hard to interpret actually were exhibiting interference. So for DQ alpha 105, what you can see is that the MFI is coming up a little bit at 1 to 10, but is clearly detectable and quite strong at 1 to 100. And so this indicated to us that the positive B-cell cytotoxic crossmatch was actually reflective of the strength of the DSA, and that he had quite strong antibodies to DQ7 and or DQ alpha 105 that were contributing to this positive crossmatch. And of course, this was a contraindication to transplant, so the patient went to paired donation. So this correlation between antibodies that are detectable at dilution and crossmatch results actually has been reported by a few studies, and here I'll highlight this study from a Spanish group. They looked at 18 highly sensitized renal transplant candidates, and they tested the serum undiluted and at a 1 to 160 dilution. It's not clear from the methods, but it looks like their serum actually was not treated with anything. But what they observed was that DSA that were moderate in the undiluted serum, but had a cytotoxic positive crossmatch, were in fact C1q positive and were still detectable at a 1 to 160 dilution. Therefore, this supports the interpretation that these types of antibodies are actually very strong and highly clinically relevant because they may cause a positive cytotoxic crossmatch. And therefore, they proposed this pattern here of risk stratifying antibodies based on the reactivity in undiluted, diluted, and C1q assay. And so what I'll highlight is that those antibodies that were detectable in undiluted serum but not detectable in diluted serum but C1q positive carried a high risk, and in their analysis of more than 30 cross-matches, all of them caused a positive cytotoxic cross-match. What's very interesting and pertinent to this discussion of serum interference is that those antibodies that were false negative, essentially undetectable in undiluted serum, but detectable in diluted serum and C1q positive, carried a very high risk in their opinion, and all again were CDC positive. And those antibodies that are detectable in both undiluted and diluted serum also were CDC positive. So antibodies that are so strong that they exhibit interference, in my opinion, are very high risk because they are likely to cause a positive cytotoxic crossmatch, which for many programs and many centers is a contraindication to transplantation. And really the only way so far that we can detect this is with serum dilution. But I think that the challenge is knowing when you need to dilute the serum, because we don't have a clear picture of what types of patients actually exhibit this phenomenon. For class 2, especially with DQ, I think that we become much more suspicious when the pattern is like the one that I showed you, where the MFI across the DQ beads is unequal, and there's no clear DQ alpha pattern. But for class 1, there is really no way to tell without doing some additional test. And because, as I showed you, different patients and different sera require different dilutions to obtain the increased MFI, it's really hard to know whether dilution at 1 to 10 is sufficient or whether you need to increase to 1 to 100 or 1 to 1,000. And for that reason, we really like complement detection assays, because they give you a clue that there might be more antibody there than you suspect or that you're detecting, and that you need to go on to do further dilution studies. So I'd like to summarize and end with the fact that quantitation of HLA antibodies is challenging and nearly impossible with essentially one test using our current methods. The limitations that prevent quantitation of antibodies include epitope sharing, as I showed you in the beginning with BW4 and BW6, as well as serum interference in some patients, and differences in affinity of the antibodies or their clonality, how many clones are present. It's important to remember that the MFI is not the same as titer. You can only obtain titer by performing a serum dilution, and you can actually only obtain the titer by performing dilution until it is certainly and definitively negative. And this is a challenge, I think, particular to our field compared with something like transfusion medicine, because titration in our solid phase assays isn't always straightforward. So in other serological assays, antibodies become negative at 1 dilution and then stay negative when you dilute further. But as I showed you, we've observed, and other groups have published, antibodies that become negative at 1 dilution but then increase again when you dilute further. So it's hard to say where the right dilution actually is to know for sure that you've completely titered the antibody out. Another consideration is that because of interference phenomenon, antibodies that are prozoned are also very strong and are perhaps the strongest antibodies of all in the serum. So because of cost considerations, we don't do a full titration study, but we feel that antibodies that are detectable at higher dilutions should generally be considered unacceptable. So even without obtaining that conclusive titer, it should be sufficient to establish that these antibodies are high risk and that there are high concentrations of them in the circulation. So what's clear is that laboratories should be evaluating methods of serum treatment to mitigate this effect, but we need more and larger studies to identify which of these treatments is the best and whether the higher MFI is indeed clinically relevant. And currently there is wide variation across laboratories in the use of serum treatment. Some use none at all, and some use EDTA, and some use melon column. And what this presents as a particular challenge to our field is that the current literature assessing the strength of antibodies with solid phase assays is muddied by the fact that each study uses a different serum treatment, and therefore their MFI readout may not be equivalent in another laboratory. So I think that was one of the major goals of the STAR workshop, was to enable more meta-analyses, at least with more transparency of what serum treatment laboratories are using, in order to be able to look across studies and compare outcomes in patients with their DSA MFI. So with that, I'll end. Thank you for listening. I hope that you've learned something valuable, and I'm very happy to take questions. Oh, yeah, I just want to say thanks to everyone for listening, and I hope that you learned something and maybe it spurred some ideas on your end for some studies to do. If you have any questions, you can feel free to email me also.
Yeah, definitely. I think you've given the audience quite a great place to start with as far as the how they can approach dilution. So thank you for that. This concludes our webcast. Thank you again for joining us today. Have a great rest of your day. Thank you.